Good afternoon, all. Yes, I'm going to be talking on an integrated approach to flatten the myopia curve.
It's not coming here. Yeah, now it's there.
As you're aware, it's one of the most common ocular disorder with a high prevalence now even in India. But unfortunately, the cause, it's not moving. The cause and pathogenesis is not understood. In fact, the impact of COVID pandemic has caused that in school-going children significant high myopic progression. But there are certain challenges, and hence managing this is becoming an issue. So with this idea in mind, we had a myopic management personalized by artificial intelligence, integrating in imaging, biomechanics, and molecular factors. It was a prospective comparative study done with ethics committee approval. What was the rationale? We know myopia is associated with hereditary, lifestyle changes, there's corneal biomechanics and topography, and molecular dopamine. All of this can be known to either prevent or treat the myopic progression. But do we really know there's an association? With this in mind, we decided our methodology, where we're starting with the questionnaire to address the hereditary and lifestyle changes, where we asked questions related to daytime sleep and nighttime sleep, outdoor activities, then screen time, hereditary, especially where there is associated parents and having it, because it increases much more if they have parents having myopia, dopamine related to mood and dietary. Once we address the question, we actually measured dopamine using the tear film from the Schirmer strips and applying ELISA clit. We know that dopamine is one of the most important neurotransmitters with a role in eye growth regulation, because decreased levels causes neural dysregulation and increased globe elongation, developing myopia. We have already published that dopamine can be detected in human tear films, and it correlates that with the plasma dopamine levels. So this, we finally included 206 children with only purely myopia and no other ocular symptoms or systemic illnesses.
Excuse me, please close the door.
This included 50 emetropes and 156 myopes, of which 45 are mild myopia with refractive error less than -3, 60 moderate myopes between -3 to -6, and 51 high myopes more than -6. We also followed them of these 163 patients. So we found there was a decreased fluid dopamine levels in myopes, and of these, mild to moderate had significantly different level, indicating that those with emetropes had higher levels. We also compared dopamine levels to myopia progression and found that at levels 13356 picograms per ml, there was a significant AUC of 0.73, indicating a high sensitivity of 82. But dopamine was not different between those that who stabled and progressed. Interestingly, we noticed that when we apply the questionnaire in dopamine levels, we noticed there was an increase in level of more than, in those which were playing outdoors for more than 2 hours. Then we came to the next aspect of Corvus and pentagram. We have previously published that there is an association between in 733 pediatric eyes that were having different grades of myopia, and found that it was negatively correlating with the grade of myopia, that is corneal biomechanics. But obviously we could not predict it with myopic progression. So let's apply it in this study. So we found out, we applied all the patients underwent Corvus and pentagram parameters, of which 61 indices and 27 of each were together used and for prediction, where we applied artificial intelligence, that is cross-validated logistic regression level. In that, for detection of myopia, we got this. The first split was at dopamine, which was more than 12871, and found that those with a high AC depth were myopics, and in those with a A2 deflection length, that is on Corvus, were found to be myopic. Those with coma of more than 0.03 and RMS of lower order aberration more than 1.79 were found to be myopic. So this had a precision of about 0.77. And if you compare that with emetropes and myopia prediction was about almost 80%. When we applied for myopia progression, we realized that the first split was axial length. And then if you have an axial length of more than 23 with a child watching TV more than 30 minutes, age less than 11, and playing less outdoors was progressive. Similarly, for those which had less spherical power, lesser age, and playing more iPad also was progressing. So this had a precision of 0.78 with stability of 88%. So what we already knew is dopamine is available in only adults, and corneal biomechanics and dopamine is related to myopia. But this study shows that it is the first study for tear dopamine in myopic children, non-invasive, correlates dopamine and corneal biomechanics with grades of myopia and its progression, and actually confirms the role of axial length, outdoor activity, and screen time in predicting myopia progression. But yes, we need to have more robustness in clinical translation of these observations and longer serial follow-ups. So what does all this mean in clinical implication? So we know that axial length plays a role. We also know age parameter plays a role, and outdoor activity. So what it does is then you have a child who has an axial length less than 23. You have somebody who's watching TV less than 30 minutes with a spherical power less than 2, and having less iPad is stable. So in these conditions, if you're allowing and you follow these patients, you can purely put them on lifestyle modifications, only cutting down the screen time, letting them go play outdoors much more, and that will help. But those where you see, where they are having a larger axial length, where you notice that they are having more time to spend, like they are studying longer hours, they are in higher standards, and they have a chance of progressing, those can be followed up closely, and eventually may start medication. Thus, we would like to conclude that AI-assisted processing of extended cohort-based information will eventually help us in early detection, prevention, and management strategy for myopia, because myopia is now already started, but going to be a sooner pandemic, just like COVID. Thank you very much for your patient listening.
Very good study. I think it can be very useful clinically in years to come. But the only problem is, yes, as you said, what we need to know are basic things, like how much the child watches TV, what's the age, what is the myopia at start level, how much does he play outdoors. So all these things are something which any general practitioner, any general ophthalmologist can also do.
Yeah, so this questionnaire is what we actually introduce. If you introduce a questionnaire and you ask these questions, realize where they fall in, and you know they are going to be in the stable level, just follow them up. If you feel there may be a chance that they are going to progress, like in children who are in 10th standard are not going to cut down the amount of reading. You know, they have a chance of progressing. Those patients can be put on an early follow-up and start on treatment and monitor them on the basis of the same guidelines that we are putting in.
Thank you, Dr. Jyoti. I have one doubt. See, whatever you are saying, that is like a didactic lecture. You are guiding us, this you should do, this you should do. But this is a pre-paper presentation. Did you study your patients? Did you collected any data using this integrated approach? And did you find anything that...
So whatever I have told is entirely on the basis of 206 patients that I have got. This is not what I am assuming. In these 206 patients, we realized that those patients who had an axial length of a particular level...
So what was the percentage of cases that you find out?
I'm sorry?
Could you have any data out of the 261 patients?
Yeah, I exactly showed 206 patients, of which we had 45 mild myopes, 60 moderate, and 51 high. And of these, we noticed that those who progressed had an axial length more than 25, who are spending more times indoors, who are not going outdoors, who are more screen time. So this is whatever I've shown. AI is on the basis of the patients, not something which I am just generally telling. Okay. This is the artificial intelligence was applied on the group of my patients, and then found. And we also have e-metropes in which we show that nothing. So we had a control group which did not show progression. This was comparing. So we eventually got a particular set of AI showed which could stay stable and could progress. So this can be applied clinically so that even for general ophthalmologists, we can be able to show that this really works, because we always say outdoor you should go, but does it really work? So this study showed that it is working on the set of our 206 patients.
Thank you.
Thank you.